Hello, my name is Ashley Rumfeld. I did my research project on the usefulness of low titer group O whole blood for trauma resuscitation versus standard component therapy in a civilian trauma center. The general characteristics of whole blood is that it is the product that is collected directly from the donor. So when you go give blood at the American Red Cross or CBCO, wherever you go, that is what they are collecting. They are collecting whole blood. Whole blood contains the red blood cells, plasma, which has the coagulation factors, and platelets all in it. Whole blood has a 21-day expiration date when collected in CPD, and it is stored at 1 to 6 degrees Celsius. Depending upon the anticoagulant used will change the expiration date, but for our purposes, we're just going to say a 21-day expiration date for this research. Packed red blood cells, fresh frozen plasma, and platelets are all made from whole blood. Basically, any of the components that are standard used in a transfusion service come from whole blood. The primary indication for the whole blood is for volume expansion and increase in oxygen carrying capacity for an actively bleeding patient. It's my understanding that colloids and crystalloids are used for this purpose right now for the volume expansion, but back in the day, they used whole blood for that. One thing to note, whole blood is not recommended for chronically anemic patients because these patients will have compensated and will have produced more plasma due to their anemia. So if they were to be transfused whole blood, that could lead to possible volume overload. Whole blood was the product of choice for trauma resuscitation clear up to the 1970s. It was used during World War I, it was used during the Korean War and the Vietnam War. During the Korean War, over 600,000 units of low titer group of whole blood was transfused to injured soldiers. They determined, according to the U.S. military, they determined that a titer of less than 256 was considered low titer, and they only had 4 transfusion reactions reported. During an 18-month period in the Vietnam War, 230,323 units of low titer group whole blood was transfused, and only 1 transfusion reaction was reported. The utilization for whole blood was replaced by component therapy because they really kind of started getting to the point where they wanted to just treat the specific problem that the patient had. Instead of just throwing the whole basket at them, they only wanted to throw part of it. So if the patient was anemic, they had a low hemoglobin, but their platelets are fine, what's the point of giving them everything? Just give them packed red blood cells. If they had a low platelet count, but their coagulation factors were fine, just transfuse platelets. So that's kind of where the industry started heading. Another thing that kept people or started getting them to where they wanted to step away from whole blood was the AABB standards for blood banks and transfusion services that required whole blood transfusions to be group identical. This was the standard clear up until this year when the latest version was released. This requirement prevented the use of transfusing low titer group whole blood to patients with an unknown blood type. The reason that whole blood was required to be group identical was because whole blood contains both red blood cells and plasma. Therefore, both the red blood cells and the plasma of the donor must be compatible with the recipient to prevent a hemolytic transfusion reaction. Whole blood has the capacity to cause major, minor, and bidirectional incompatibility with the recipient. So it's really important that the recipient is transfused compatible whole blood. Group O whole blood contains both anti-A and anti-B in its plasma. It is very important that anti-A and anti-B titers are tested and found to be low before transfusing a unit of group whole blood. There is no standard requirement for what low titer is. That is up to the facility to determine what they're okay with. But it is theorized that the amount of the level of the titer can indicate the amount of hemolysis that a patient could experience in a hemolytic transfusion reaction. So basically, a low titer could mean that you could have little to no hemolysis, Whereas if you had a donor with a high anti-A and anti-B titer and they were transfused to a non-group O patient, that could be really detrimental to that recipient because it could indicate that a transfusion reaction would occur. In April 2018, the 31st edition of the standards for blood banks and transfusion services went into effect. In this new standards, there was a revised standard for whole blood, and it states that recipients shall receive ABO group compatible red blood cell components, ABO group specific whole blood, or low titer group O whole blood for non-group O or for recipients whose ABO group is unknown. What does this mean for us in the transfusion community? This means that it allows transfusion services the opportunity to implement a whole blood program if they so choose. This will give them another way to treat patients who are coming in actively bleeding and they need to treat that and perform trauma resuscitation by giving them a way to just hit them with everything right when they come in. They get one bag, it's right there, it's uncross-matched. It gives them that opportunity. Possible benefits of whole blood is decreased turnaround time for the patients to receive transfusion. There's no thawing of plasma. Simplification of the process because only one product is needed versus 3 products. In addition, whole blood provides a balanced restoration of oxygen and coagulation factors because it has everything in it. And it is a more concentrated product because it has a reduced amount of anticoagulant and preservative solutions compared to standard components. Due to the revised standard, renewed interest in whole blood transfusion has emerged, especially in military situations in austere conditions. The Norwegian Naval Special Operation has developed a protocol for whole blood to use in austere conditions. This protocol includes 2 methods, the buddy transfusion and the walking blood bank. The buddy transfusion is more of an old school technique that was utilized back during more like the World War I and stuff like that. This type of whole blood transfusion is performed when no bleeding products are available and the soldier is actively bleeding. It is performed under extreme conditions and as a last resort. It depends on accurate blood typing of both the donor and the recipient prior to the mission. So basically, when it is determined that an injured soldier needs a transfusion, they're not going to make it without one. They determine what that injured soldier's blood type is. They should have some type of identification on them. And then they try to find a compatible donor. They literally will draw that donor in the field, and they will transfuse that soldier in the field. So there is no testing whatsoever done. It's very risky, in my opinion, because it's depending upon accurate results prior to the mission. And we all know that like I've experienced where the blood type on doc text isn't right. So to me, it seems really risky. The second method is the walking blood bank. All the blood titering for anti-A and anti-B disease testing are all performed on the donors prior to the mission. The personnel that are on the mission will attend extensive training in regards to whole blood transfusion, the requirements, what to watch for, etc. Any donations that they're going to take with them are collected in CPD, and they are stored in a golden hour box at 2 to 6 degrees. All personnel are required to have some type of identification specifying their blood types at all times. But they do recommend using low titer group of whole blood in these situations because it can be so chaotic. It's just uncross-matched. It's given to them. So there's no testing at that time. The University of Pittsburgh Medical Center implemented a whole blood program in 2016 and began collecting data. They decided to do this based off of research and protocol provided by the U.S. military. They, in their program, they only used male donors. They used low titer group O Rh positive whole blood collected from male donors only. They determined that a low titer for them would be considered a titer less than 100. The reason they only used male donors was because they wanted to prevent Charlie. The whole blood was stored at 2 to 6 degrees and was kept in transfusion services up to day 14. If the whole blood was not used by day 14, it was returned back to the blood center and converted into a packed red blood cell at that time. The plasma and the platelets are discarded, and it has like a 7-day expiration date from that time. 6 or 7 days. To be eligible to receive whole blood for trauma resuscitation in their program, you have to be an adult male and or a female who is over the age of 50. You have to be hypotensive with a blood pressure of less than 90 millimeters per mercury due to active bleeding, and you must meet ABC criteria greater than or equal to 2 to be eligible to receive low titer group O Rh positive whole blood of up to 4 units. In addition to their adult program, they also implemented a pediatric whole blood program at their pediatric hospital. These patients have to be at least 3 years of age, and they have to weigh at least 15 kilograms to be eligible for 30 mLs of low titer group O Rh negative whole blood. Females of childbearing years are not eligible due to possible de-alloimmunization. They do not want to have to deal with that, so they don't let them be a part of the program at this point. Basically, what happens is they have 4 units of low titer group O Rh positive blood stored in their cooler in the ER at all times. If a patient comes in that meets the criteria, that they can receive up to 4 units of uncrossmatched low titer group O Rh positive whole blood while the pre-transfusion testing is taking place. Once all 4 units are received, that patient is then switched to component therapy. They do not get more whole blood. Upon admission and hopefully before transfusion, baseline labs are collected for LDH, total bilirubin, and haptoglobin, in addition to the regular labs that you have in an emergency situation. Also, in addition to the clinical findings and the complete blood cell count, these labs are used to monitor the patient to determine if they are experiencing any hemolysis due to a possible transfusion reaction because they received the low titer group O whole blood. What they found when they did their research is they collected data from the patients who received group O, low titer group O whole blood, and they compared it to data collected over 2 years of patients who received standard component therapy. These were patients that were similar in demographics. The results between the two methods were not that different. It was not more dangerous for a patient to receive the low titer group O whole blood versus regular component therapy, nor was it necessarily superior either. It seemed like the outcomes were pretty much the same. They did like it because they were able to give everything in 1 unit right as soon as the patient presented. That appealed to them. While the pre-transfusion testing is occurring, they wanted to be able to start getting that patient going with that uncrossed group O whole blood. Conclusions. To me, the use of, like I said before, the use of low titer group O whole blood doesn't seem to be any more dangerous than component therapy, nor does it seem to be superior. This pretty much seems to be comparable. In my opinion, it would be most useful in the pre-hospital environment, such as like ambulance or in the helicopter where space is limited. It's hard to get multiple IV sites in. You only have 1 bag. You can give everything you need from that 1 bag, especially if you're picking that patient up at the scene. They're already actively bleeding. Start transfusing them then. I think that could possibly increase, the patient outcomes at that point. As far as the research I was seeing so far, excuse me, I do not think it would necessarily be beneficial to implement a group O whole blood, low titer group whole blood program in a transfusion services setting. The reason I think that is because it's just the amount that you're allowed to give. you're not allowed to give that much at this point. I have been involved in MTPs or trauma activations where the patients have used 40 to 50 units, sometimes even more. And when you're talking about 4 products versus 40 to 50, it doesn't really seem to be that big of a difference to me. I don't think it would make a huge difference, especially into regard to the amount of work you're going to have to put in to maintain that whole blood program, to implement it, to make sure that clinicians are only giving whole blood to patients that actually qualify for it and meet eligibility requirements, to make sure that it's being used properly, to manage that inventory and make sure you're not having extreme wastage. I think there would be a lot of variables that would have to take place to have that in place in a transfusion service. And when you can only give 4 units, it just doesn't seem worth it to me. However, if they ever did enough research where you could use whole blood throughout a whole MTP, it would simplify the process. It would be faster because you're not waiting for plasma to be thawed. You're not waiting for the blood center to bring you more platelets. So there wouldn't be a delay in care whatsoever if you could use it throughout the whole entire process. But there's going to have to be so much more research to be done before that is allowed, in my opinion. Another reason I don't think it would necessarily be that great of an idea is because when you start implementing a whole blood program, especially at a lot of hospitals over a city, that's going to really start affecting your platelet inventory because platelets come from whole blood. And especially when they have to titer these different donors for anti-A and anti-B, if it is found that those donors have high titers, at that point, they're no longer eligible to be platelet or plasma donors. They can only donate packed red blood cells. So that could really decrease the amount of platelet donors that you have in your location that you live. Also, this program had a 12% wastage rate of whole blood units that they did not get used and get converted whatsoever. That seems like a really high wastage rate to me. And we all know that wastage is very costly to a facility. So to me, that just seems like a big detriment. The last thing I want to talk about is how when you start using like our current way we calculate platelets, if right now we use apheresis platelets, if you switch to whole blood, at that point you're going back to random donor. So when they start doing the calculations, I can just see that being really confusing to nurses and clinicians. And we already get a lot of phone calls about this. And so I could see that being very detrimental. One more thing, I'm sorry, I forgot to mention earlier, is that when they are collecting the whole blood for this program, they use a special collection in order to do that. They use a Terumo Imuflex whole blood SP blood bag system. This provides leukoreduction and it leaves the platelets functional. It's the only kind that does leave the platelets functional. Any of the other leukoreduction systems don't leave the platelets functional for whole blood. Oh, and then one more thing, the 14-day, the reason they keep the units up to 14 days, because after 14 days, they have noticed that the platelets and the coagulation factors are diminished. So that's why they kind of have that 14-day cutoff as well. That is really all I have to present at this point. It was very informative to learn about this, and I hope you enjoyed it, and I hope you have a great night. Thank you so much.